So there's a broad range of things that we see on the consult service. And so the next couple of cases that I will be discussing will really be focused on issues that we're seeing on the Heme Consult service in the hospital. The first case that I want to talk about is a case of a 52-year-old female who had a history of a hip fracture, and this was about 4 months prior to this current admission. Now, at the time that she was admitted for the hip fracture, she was incidentally found to have a mass, and she got a full body scan that also demonstrated that she had an incidental finding of a pulmonary embolism. So at the time, the mass was being worked up, she did have the hip fracture repaired, and then she was going to be sent out on therapeutic anticoagulation, and the decision was made to start her on enoxaparin as a bridge to warfarin because she was on a medication called phenytoin. And the goal had been to transition her to a direct oral anticoagulant such as apixaban, but there was a concern for an interaction between phenytoin and apixaban. For that reason, she was not transitioned. She was instead put on enoxaparin as a potential bridge to warfarin until she could be transitioned off the phenytoin. And so we are now meeting her in this hospitalization 4 months after her initial admission. And so the question we are asked is that this patient missed starting her anticoagulant therapy. So she took her anticoagulation for a total of about 9 days and is now here with a hip infection. What do we do about the fact that it's been 4 months later, she has not been therapeutically anticoagulated, and she's not showing any signs and symptoms of a new DVT or PE? All right, so the 3 points that I want to address in this particular case. Point number 1 is the importance of understanding the drug-drug interactions that can happen with anticoagulants. For warfarin, we know that there are myriad drug-drug interactions, but we don't think about these drug-drug interactions as much when it comes to the direct oral anticoagulants. So for this patient, she was on a drug called phenytoin, and apixaban was considered in her, but was not started because of the drug-drug interaction. Both direct oral anticoagulants, apixaban and rivaroxaban, interact with PGP and CYP3A4 inhibitors. And so you want to make sure that you are not on these medications concurrently with medications such as phenytoin, carbamazepine, which could decrease the efficacy of the anticoagulants. So it's important to note and look out for these drug-drug interactions. That's point number 1. Point number 2 is that in this patient who's now 4 months from their acute venous thromboembolic episode, do you now, after the fact, go back and anticoagulate someone who, should have been anticoagulated but was not? Should you just say, well, the acute thrombosis is over, the risk of thrombosis is done, and just say, well, I guess you got lucky? I think the right answer to that question is that this patient has not been therapeutically anticoagulated. She has not had a trial of therapeutic anticoagulation for her acute DVT PE. She had a PE. She has not had a therapeutic trial of anticoagulation for the pulmonary embolism. For this reason, she deserves a full therapeutic course of anticoagulation, and she should be placed on therapeutic anticoagulation. So that's definitely one reason to consider. There's no contraindication to anticoagulation in terms of bleeding or concern that would cause you to hesitate. And so she really should be given an adequate trial of therapeutic anticoagulation. However, also considering that she is currently acutely ill with a prosthetic joint infection, and she has a mass that has not yet been worked up. For this reason, with a strong concern for malignancy, whatever her predisposing factor was, which probably was the hip fracture at the time of her initial presentation, is probably still present, and this mass is not worked up. So for many reasons, I would say that this patient is a candidate for continued therapeutic anticoagulation to complete really a minimum duration of 3 to 6 months, because we would consider this a provoked thromboembolism. In the meantime, she does need workup for the concern for malignancy so that we know that she does not have an active cancer that may require her to be on anticoagulation for an extended duration of time. The third point that I want to raise is that this patient has a mass in her pelvis, and there is concern that she might have a gynecologic malignancy. And so it's going to be really important to address this concern for malignancy as quickly as possible, because that may impact your recommendations for therapeutic anticoagulation. All right, that's it for that case. Thank you for listening.